welcome to the Brinker Leadership Series, Extraordinary Leaders in Extraordinary Times by Adi Partners. I am Hiral Desai.
COVID-19, the pandemic of this millennium, has changed our daily lives irrevocably. We believe people fighting this pandemic at the coalface in healthcare, travel, supply chain, government, non-profit, and media deserve recognition. I am Sanjay Viswanathan.
Through the Brinker Leadership Series, we're identifying extraordinary leaders in these extraordinary times. And this is very similar to legendary 15-year-old boy who mythically saved his nation from being flooded. The series will provide everyday leaders a platform for sharing of best practices and appreciate their efforts in the fight against COVID-19. Our journey will take us to India, Middle East, UK, Europe, America, Far East, and China.
This war against the coronavirus is being fought on physiological and psychological terms. Our brave armed forces are doctors, nurses, social care workers, and frontline professionals in multiple sectors. In this episode of the Brinker Leadership Series, I'm pleased to introduce you to a champion of healthcare. Please welcome Dr. Madan, GP and partner of the Hurley Group. Arvind has been a general practitioner for 23 odd years and is a founding partner of the highly regarded Hurley Group in the UK. The Hurley Group provides NHS general practice to over 100,000 patients and urgent care to over 250,000 a year in London alone. The Hurley also delivers the National GP Health Service for doctors with mental health issues. What makes Arvind truly fascinating to have him as one of the cohort of champions, as Hiral put it so eloquently, is he's also the co-founder of a world-class technology platform called eConsult, which is now UK's largest online and telehealth platform that serves 21.5 million residents across the country. Welcome to the show, Dr. Madan.
Thank you very much.
Dr. Madan, it's great to have you with us. You've been on the forefront of this battle against COVID-19. Could you give us an idea about your role and what is your experience?
So I'd probably start by just adding a couple of points to that introduction, which is feeding my imposter syndrome further, particularly when it's titled Extraordinary Leaders. And I think this is a time of extraordinary teams rather than individuals. I've not been promoted to the ex-CEO of NHS England. I was the Director of Primary Care and Deputy Medical Director. But in terms of what my role has been in relation to COVID, as you say, Sanjay, we have 115,000 registered patients who we see on average 5 or 6 times a year. And we have near 250,000 patients coming to see us in urgent care. And services have transformed sizably since the last few weeks and months. And to give you a taste of that, the vast majority of care was delivered previously in face-to-face 10-minute appointments. That has changed completely. So in general practice in England, with a population of 60 million patients, probably general practice was seeing somewhere just north of 300 million attendances a year. And as I say, the majority was face-to-face. But now, each of those 7,000 GP surgeries are probably only seeing a handful of patients face-to-face, with the majority of care either being delivered over the phone or through online consultations. And NHS England has recommended that every patient is triaged in advance of attending a physical premises. So that means that they are communicated with to confirm whether they should come into the site or not. General practice has reorganized itself across populations of 30 to 50,000 called primary care networks, of which there are 1,250 in England. And those primary care networks have rearranged which practices are going to see hot patients, patients suspected of COVID, ones where it's not obvious that they necessarily need to go immediately to hospital, but equally they can't be left at home unassessed. They're brought in to a hot hub where they're assessed, and then they transfer on to hospital or go back home for isolation. And for example, locally, we've set that up with the local black cab taxi organization, who clearly have less business at the moment. So patients arrive in the back of a black cab. They're assessed in the car park of the surgery. Their observations are taken. Decisions are made over how unwell they are, and the cab then drives them to hospital or drives them back home with a support package to help them through that difficult period. So that gives you a sense, I guess, of the way in which services have reorganized. Total triage, online and phone first, hot and cold hubs, and the cold hubs are aggregating the depleting workforce due to their own burden of illness into fewer sites where they're dealing with patients where the suspicion of COVID is far less.
Right. So, if you could just help us understand, what is the situation looking like on the ground in terms of the number of patients, the type of patients that you're treating on a daily basis now versus what you were treating pre-COVID?
So pre-COVID, obviously, was the full gambit of everything that comes to a family practitioner, and everything from acute same-day need issues, as well as the routine long-term condition care. And in the UK, we do a fair amount of preventative screening type care as well. Now, the care mix, I guess, is more dominated by patients with suspected COVID, making decisions through this new architecture in the system. And it has to be said that patients, you're right to say, who are suffering with their long-term conditions are more reluctant to come into the practice physically for ongoing care. What we are doing, however, is saying, okay, well, look, if you've had an abnormal smear in the past, you should still have that. If you are due childhood immunizations, we should still go ahead. We should still be doing those baby checks. Blood tests are still going on. But obviously, staff are wearing full PPE. But the other thing I would say is around mid-March, when our lockdown really took effect, is a good proportion of the medical workforce picked up their laptops and went home, and are now doing a great proportion of their care remotely, either through the use of text message, post consults, email, through telephone, through video. So those mediums have really gathered momentum during this period.
Right. So, if you have to compare the current pandemic, say to SARS, MERS, H1N1, that you've already faced in your career so far, how is the situation different if you have to compare?
Yeah. So, I mean, clearly SARS and MERS were more regional. The number of cases were fewer. And although the mortality rate was higher, the overall global impact was less. And I think one of the key differences here is that the prodromal phase of the illness means that the infectivity of COVID is far greater. So whilst for a good proportion of patients, it's a mild, self-limiting, or even asymptomatic illness, for a small proportion, it is clearly catastrophic and can lead to high mortality rates when you consider the absolute numbers of patients infected. So that's probably the key difference, I would say. More infectious, but hitting more people, and therefore absolute numbers in terms of mortality are far higher.
One of the things that you spoke of, Arvind, which I truly find fascinating, is how you guys leverage the London cabbie, which is such a brilliant on-the-ground strategy of leveraging one of the city's big strengths, isn't it?
Well, I mean, it was, I can't claim credit for that idea. It was one of my partners. But actually, it's a vehicle where there is already an existing partition between the driver and the passenger in terms of a screen. Both doors can open pretty wide, so you get some ventilation. They're easily cleaned with disposable chair covers, etc. And therefore, with those guys all sitting around with no business, feeling sorry for themselves, quite understandably, it felt like a potential win-win with our particular logistical challenges.
Indeed, and you put it very well. And for some of our viewers who don't know about the key characteristic of the London cab is just the amount of space you have at the back.
Yeah.
Especially for patients to be rolled in, even with a wheelchair, for instance, or with carers, isn't it? And on that vein, when we talk about some of the strategies that governments are deploying around the world, I mean, it's quite fascinating to see what the UK did with Stay Home, Stay Safe, and Save the NHS, which I think embellished itself around the world. What did you see as the impact of this mantra on the ground, Arvind?
Well, I think whilst it has been effective in terms of flattening the curve, which was the key aspiration of government. So that by that, what I mean is it meant that we kept the incidence and prevalence of the disease in the community to within the NHS's capacity, and therefore, fortunately, we didn't have the kind of scenes here that we've had in other countries, for example, Northern Italy, where services were really very hard pressed. We were able to contain the pace at which cases appeared to well within NHS capacity. And for example, in East London, they converted an exhibition centre, the Excel Centre, into a hospital within 10 days, with 4,000 bed capacity with ventilation. And actually, only a handful of those beds have ever been needed, but the safety valve was important to put in place. So we were, there was probably, in terms of the government's key aspiration, some measure of success in containing that. What will happen with second and potentially third peaks, if they occur, is yet to be seen. And clearly, it's the government's intention to try and avoid that. But we've also had criticism here about whether the lockdown was a little late, whether it was a little loose in its implementation, the challenges around PPE and testing. But overall, I think the situation has been, in areas, handled really well, in areas more questionable, and no doubt there will be an inquiry to follow. The other thing that we've done here is that we've risk stratified the population so that we can identify those who are extremely vulnerable and most risk of issues with catching COVID. So probably somewhere around 2.5% to 3% of the population with comorbidities have been identified and communicated with to say operate a strict isolation policy. So there are home delivery packages of food, there are preferential arrangements for them to order online. There are 750,000 people in the population have volunteered to support those people. So every day there's a couple of 100,000 phone calls going into those 3% of the population to just make sure they're doing okay and keeping their morale and spirits in a reasonable place. I mean, the new situation is around loosening the lockdown. The phrase "stay alert" has been used. And there is some criticism over the vagueness of that expression. But equally, governments have a really tricky job to balance saving lives and saving livelihoods, in a sense. And clearly, it's not the case that an economic depression or recession doesn't have its own death toll attached to it when deprived communities are hit by economic hardship. The difficulty with some of the current guidance is that it requires a degree of interpretation, really. And there is some anxiety around the middle of next month, maybe opening up some of the primary schools, and some nervousness in the population about whether they're happy to let their children go to school even. I think the government here is taking a balanced approach in as much as they're trying to use the R number, the number that will determine how many patients are infected by each infected case, as a measure. So a bit like a sort of terrorism alert scale, using something like an R number to help the population leverage up or down the measures it takes in terms of social isolation related to the emerging data on how the infection is progressing and how that, if that curve is staying low, which I think is probably the right approach to optimize saving lives and livelihoods. And it has to be said that there's a fairly generous economic package that's been put in place, although there are cracks in that, and there are examples of people who fall through those cracks and who are already suffering hardship.
Another thing is that the mortality rate amongst the healthcare professionals, that's looking worrisome right now. Are these numbers that are being projected normal, or do you think that's something really abnormal, something needs to be done? Because as a healthcare professional, what would your suggestion be to the fraternity to prevent further mortalities?
Well, clearly we've had challenges with PPE in this country, and actually first and foremost, it's really vital that we get that right and use the right PPE that's evidence-based in the right circumstances to protect staff. Later this morning, I'll be going to one of our sites, and I will be ensuring when I arrive there that they're maintaining social isolation. That's one of the purposes of my visit, frankly, to make sure they feel supported in that. And I think the sort of higher mortality rate that's being detected in healthcare workers has been it's been postulated that that's because they're receiving a higher initial viral load at exposure, because they're in close proximity to patients who are highly infectious and shedding large volumes of viral particles. So that's probably it. But I guess there's another trend I'd like to just kind of highlight, particularly in current company, is that actually Black and ethnic minority healthcare staff are suffering particularly heavy losses in terms of mortality. So they represent about 14% of the UK population, but they're 44% of doctors and 20% of nurses, but the death rate is 70%. So the first 10 doctors to die in the UK were from Black and ethnic minorities, and they now represent 94% of the first 20 doctors to die. So actually it can give you an idea that there may be something going on that might be beyond the comorbidities or age or other profiles to explain this. Now, the government has done some investigation into this, and whilst they haven't received any, arrived at any definitive conclusions, it's been sufficiently worrisome to suggest that they risk assess Black and ethnic minority staff within the hospitals and within primary care. And then within my own organization, we are moving, staff of Black and ethnic minority groups away from the front line and the highest levels of potential contact with patients. So I think these are some of the things that are happening at the moment that are affecting the medical world particularly. But I mean, it has to be said, we have to pay tribute to the guys who are going in and seeing these patients, knowing that they're running a risk for themselves and their families, and they're the real heroes.
There's another aspect that we want to talk about, which we know you're quite passionate with, and that is the introducing game-changing technologies in your primary care pathway. You've been one of the pioneers of that within the NHS. So one of the things we'd like to understand is, how do you see in now this COVID and post-COVID era, the advent of aspects like telemedicine, virtual technologies in medicine, et al.?
Well, we're seeing progress in relation to this in a matter of weeks and months that would, in a previous era, have taken years. So the level of permissiveness of the regulators, the speed at which services are being commissioned, the rate of adoption by clinicians, the rate of adoption by patients, it's probably fast-forwarded us through, half a decade of what would have been otherwise a slow uptake of these kind of technologies. For for my own part, I guess the thing that I've been closest to is in relation to online consultation. So some years back, we took a decision around trying to use technology to replace the face-to-face consultation. And whilst that is the gold standard, I don't think it's now the only gold standard. And what I mean by that is actually we created algorithmic, dynamic questionnaires on every symptom, every condition that commonly comes into primary care so that patients could complete them. We're inside the NHS app. We're inside, obviously, on our practice websites. And we ran this as an internal experiment, really, to see whether we could actually have patients send in their story and we then make a decision on what to do next, rather than only deal with patients in the unit of a face-to-face 10-minute appointment, which is obviously potentially cumbersome for patients, taking time off work and traveling, and not always necessary from a clinical point of view to manage that case safely. So we developed this model called eConsult, which went beyond the sort of transactional relationship of booking an appointment, cancelling an appointment, viewing your records, getting a repeat prescription, and actually started to try to replace the appointment itself. And what we found is a few things. Firstly, that there was a delicate balance that needed to be struck between patient convenience and practice efficiency. You make it too easy, and you risk running high levels of supply-led demand. So patient-instigated video would be one example, potentially. You make it too hard, and you alienate your patients, and you might be prejudicing vulnerable patient groups by mandating that they have to come in online before you will offer them a face-to-face appointment. We also found that Black and ethnic minority groups took to it quite quickly. Mainly because I think they were from quite computer savvy households where they were already Skyping India, Bangladesh, other places, and had extended families who were keen not to take the afternoon off work themselves and would help mum or dad complete a remote consultation. We found that we shouldn't be prejudiced against or bring our own biases to the question of who will use it. We have very elderly patients using it for minor conditions, and actually, that works pretty well for a lot of people. We also found that the nature of the conditions which, so for stigmatized conditions like sexual health and mental health, actually patients presented earlier online because perhaps they felt more digitally disinhibited to do so. And so where we offered this internally, what we found is that patients like the 24/7 access. They like the fact that they didn't have to hang on the phone at 8 o'clock on a Monday morning or wait 2 weeks for a GP appointment. The doctors liked it because it was asynchronous in how the work came in, so they could plan it into their working day or give these cases to the nurse and these cases to the pharmacist, and they could decide which timescale to get back to the patient in that was proportionate to the acuity of the case. So they could plan their workload. So a proportion of the demand coming into the surgery could be managed online. And then you can also add into that the ability to pick up the phone and add video. So what we found is pre-COVID, 87% of cases we could deal with without the patient needing to come in. Post-COVID, we're up to 95%. So only 1 in 20 patients is coming in who does a remote consultation because we've now developed a toolkit of solutions to manage their problem remotely. They send in an online consultation. We can, get back to them with a post-consult message and send the prescription to the pharmacy for home delivery. The guy doesn't need to get off the sofa anymore to deliver their healthcare potentially. We're also branching out into the use of the asynchronous structured history template into the front end of hospitals. So the accident and emergency department, the self-check-in screen, where a patient arrives in our sites now, they don't go to a receptionist, they go to a bank of iPads on the wall, they enter their details, it matches them with the national spine, so they have their national record attached, and then they put in the details of their illness or injury, and we can then summarize that, send it through to the clinician, and they can make a decision on what to do next with that patient. But crucially, what it does is it stratifies the acuity of the case. So someone who has sepsis or a heart attack or subarachnoid hemorrhage, we can pull that case straight through rather than sit them there in the waiting room for an hour before they're triaged by a nurse. And we can also say to some patients that actually, here's some advice, and we navigate them off to other services because they don't need to be in an emergency setting. And that's been received really well by other hospitals. So we have a number of hospitals into which we're mobilizing that e-triage model. And now we're starting to think, well, actually, why do we need 100 million people coming into the hospitals every year for an outpatient appointment? The national long-term plan around that is to reduce that by a third. So we are now working with gynecologists, rheumatologists, dermatologists, cardiologists to say what proportion of the cases that you're seeing, whether it's first appointment or follow-up, could we be dealing with this remotely? We will capture the information from the patient. It will be summarized. You will get the key information highlighted. You can process that in 2 or 3 minutes, and you can decide which patients should be dealt with remotely, which ones you actually need to see. And I think what we're going to increasingly see, we're starting to pilot the ability to take biometrics from the smartphone camera so that we can add the pulse, blood pressure, respiratory rate, oxygen saturation, temperature into that richness of data that the clinician is using to process that case. It's important to say that within all of this, it's not our ambition to kill the doctor-patient relationship. There is something magical and special about that.
Indeed. And the aspect that I find quite compelling in what you say is when you add on top of patient convenience and practice efficiency, the aspect of creating impact through outcomes, especially some of the elements that you spoke of. And when you put all of this together, Arvind, in what we think is going to be the new social norm and behavior, right? I mean, we're going to be talking about going to a mall or a cinema in the past tense. And we think about the new behavior going forward. And when you see that from a clinician's point of view, how different is the world going to be post-COVID?
So I've not lost hope that we can both go back to what was good about before and retain what we've learned as a result of this situation, and blend the two. And I remain hopeful. I mean, climate change failed to unify, global opinion on doing something concerted. But I think COVID is possibly different in as much as nobody's safe till we're all safe, all 7 billion plus of us. And I think most governments will realize that. So there will be a degree of altruism, I'm hoping, in the sharing of the science and sharing of the vaccine and making it affordable to countries who are struggling. And I think this is an opportunity to reimagine how we do healthcare within all of that. I think we've leapfrogged a few stages in development, and actually we've normalized a way of delivering care that I couldn't have imagined at when we were celebrating New Year's Eve for 2020, right? I think what we've found is there's a newfound respect for health services internationally. Thursday night, everyone's on the doorstep clapping. And actually there's a new respect for how people will use services. Yes. I think there's a new generation of people now who are feeling more empowered in how they manage their healthcare issues. And I think probably tools such as ours will bring a degree of transparency to how that interaction happens, and hopefully restore some of the trust that's been lost in some health economies between doctors and patients. So I'm hopeful we'll be able to go to a mall at some point and go to a cinema again and do all of those things. Clearly, it will have to be after we've got a more definitive, longer-term set of measures, whether that's effective treatments or vaccines. But I also think that life will be different because actually people will be more consumerist about their healthcare, and possibly that balance needed to shift. It was too much in favor of the protectionism of the medical fraternity.
Indeed. That was a fascinating discussion, Arvind. And when Hiral, you and I think about putting this in perspective amongst all the other conversations we've had across healthcare and various sectors, I find it truly remarkable how when Arvind talks about reimagining healthcare, this is really that moment, don't you think, Hiral?
Absolutely. I mean, great insights, Sanjay, coming in. In fact, thank you, Dr. Madan, as well, for tuning in. We'll thank all the viewers as well. Sanjay and I will be back same time to share more about extraordinary leaders in these extraordinary times. See you soon.
Thank you.